Yeah.
Because there's a lot of stuff we're going to ask you.
The problem is that I have so much blackmail material that you can't blackmail. Like,
Did you know this?
There's
Well,
so
this
much out
The
there.
thing is, if you're open to all this stuff and it doesn't bother you what people have on you, you can never be blackmailed.
Exactly.
Yeah.
Nothing.
Well, hello and welcome to the 27th Degree with Chris and Nancy. So today we're going to be discussing orthopedic surgery, focusing on the shoulders, with our guest, Dr. Mena Mesiha. And we have a surprise special guest, Dr. Mena Mesiha. And Dr. Mena Mesiha is Dr. Mena Mesiha's mother. And
she's going to be doing all the fact checking for us.
So
make
we
sure
thought
you
she
tell
had
us
to
the
come on
truth.
just to tell us a little bit about Dr. Mesiha's upbringing and that. And we have some questions we have to ask. But
And professionally speaking, just so we're clear, my father was Dr. Mesiha. My mother was always professionally Dr. Sidham. So
Okay.
if there's anybody listening, and actually she has a big fan following, so you will get a big pharmacy contingent watching this from New
Dr.
York.
Mena Mesiha is a doctor in pharmacy. So, but before we begin our conversation, I want to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27 Degree with Chris and Nancy by signing up as a patron. Go to patron.podbean.com/the27degree, or you can click on the link on our Facebook page. $5 a month gets you a shout out, exclusive content, sneak peeks for upcoming shows. You can find the 27 Degree across social media, including Facebook, Instagram, and your favorite podcast platform. You can also subscribe to the 27 Degree Consulting channel on YouTube. So let's start. Tell us a little bit about yourself.
So my mom's here, so I'll have to start. Okay, she's there.
So we have to keep it clean. Yep.
Yeah, so I'll leave out the things that she doesn't know about.
It's going to be a short show.
So I grew up for the first 5 years of my life in Egypt. Both of my parents were actually professors of pharmacy at the university there in Asyut, which is a couple 100 kilometers south of Cairo. And when I was 5 in 1985, they got an invitation to visit Puerto Rico, which sounded like really cool and okay, tropical island, and in the U.S. Ecosystem. And initially, it was supposed to be just like a year or two, and then eventually 2 years became 3, became 4, and they were like, okay, like this kid's done most of his education here in the U.S. There wasn't a big Egyptian community at the time in Puerto Rico, and they were looking at different options, and we ended up in New York for a while. And eventually, I went off to college and moved to Boston after college, and met my wife. Went back to med school in New York, and then I was lucky to go to Cleveland still married. So my residency was in Cleveland, and I'll never forget calling my wife and saying, "I matched in Cleveland," and all you hear on the other end of the
Silence.
So she was kind enough to go with me, and then we've been back in the area here since 2012. I did my fellowship up here in Boston, and then I've been practicing here in Fall River since I finished my fellowship.
That's great.
Did you always know you wanted to be a doctor?
So it's interesting that my mom is here. So she always knew that she wanted me to be a doctor.
You saw it in him at an early stage. Go ahead.
No, please. Tell us.
We want the inside scoop.
It's not like I wanted. It's just like, I don't know. I think I don't remember that I pushed towards that. But because I can say one thing, maybe you forgot about it. When he applied first for college, we thought maybe to go to the 7-year or 8-year. Sure. I said, no, I don't want to commit to medical. Maybe I may not like medical. Then that's why he went to Cornell for the first 4 years. After
Great
that,
school.
he decided to go where. But it's not like I wanted push him. Like their some parents push kids. I have one of my colleagues pushed his son for medical school. Oh my God, he's now
No, done with it.
terrible.
Yeah.
Oh.
Yeah, you have to want it. You have to have that desire.
It's good to give directions, but not
Right.
pushing or like that's the way it has to be.
You're right.
Right.
You're right.
That's what I think. And I don't think we did that. Maybe we recommend. I can say recommend.
Was it a strong recommendation?
So I want you to read between the lines and listen between the lines when she says, "Yeah, recommend, give direction," right? So when
But you
someone
were interested in science too. You did a lot of projects when you were high school for the college and for the high school for the research, and in the college at the Cornell you were in the presidential research program. These are
So you knew in your heart that it was going to be a
Exactly.
good match.
It's
and make
it's
'em happy.
mentality.
Yes.
Because I know
Right.
with this route or this route. Then he
Yes.
was towards that route, or that's his like
His inclination.
strength.
Yes. Yeah.
So I'll tell you two things. Number one, I wanted to do an engineering undergrad,
Yeah.
and my sort of interest in high school were a lot more math than science, and I think that was sort of like the first impasse of like, no, why would you want to do that? And I'm like, because I'm really good at math. And no, you want to be a doctor. And I was like, okay, well, why don't I do engineering pre-med? And it was like, no, that's going to distract you from like the real stuff.
I remember that discussion. Really, I don't remember.
Of course
not.
He doesn't
Remember
forget
things so
anything.
differently.
There's a lot of engineering in
doesn't
surgery.
forget.
And so I ended up coming into an engineering field sort of through the back door, because that's what I should have done that like to begin with.
Right.
And then I found myself like doing biology, which like doesn't suit me at all. Like it's all memorization. Like there's very few concepts in biology. I did neurobio, which was a little bit more conceptual than other parts of bio. But like even in med school, like they'd give you stuff to like memorize, and I'm like, if I can't get a mnemonic, I'm not going to memorize any of this stuff. And then things that were like concepts based, that were like physics based or like math based, like physiology.
Yeah.
That's
like-
what drew you in.
Yeah, I mean that's the like that to me, like the engineering of the human body. That's what really gets me excited.
Right.
And the day that I'll tell you the exact day where I decided, all right, I think I can make this work, because there was some direction from certain people. Recommendation, right? Soft, guidance to go to med school. And I was like, I don't think I like it's just like it's all this and that, and like I don't like any of that. And I went to Cornell Med, so they had like this 1-week program for Cornell undergrads where you could go shadow different doctors.
Oh,
And
nice.
it was really cool. Like
That's
they give
great.
you lectures and you walk around the hospital with them. And I remember one of the shadowing things was GI. And I walk in and there's like this, cute little old lady, and, the GI doctor, puts her to sleep, and all of a sudden he pulls out this colonoscopy tube, and I'm like, what are you going to do with that? And he proceeds to start with the colonoscopy, and all of a sudden we're not really looking at where the scope is, we're looking at the screen. And he's explaining to me like, oh, this is the ascending, this is the descending, and oh, you want to go to the this and look at that. And I'm watching him, and like, he's kind of like, like doing this thing. And I'm like
Playing a video game.
essentially a video game. And he goes, yeah, it's pretty much just like Nintendo. And I was like, I love Nintendo. And every time I go to the OR, you can truly and honestly ask any of the staff that work with me, like, they know, like, every once in a while, I'll just stop and be like, can you believe this is a real job? And they're looking at me like, oh, my God, get over it. Just do the case. Because it really is, like, someone's shoulder hurts, right? And I can't believe it's a real job. They're like, oh, yeah, let me sign a piece of paper, and you're going to put me to sleep, or somebody else is going to put me to sleep. And while I'm sleeping, you're going to fix me and it's going to look just like video games. I'm like, no, that can't be a real job. And I think it's a privilege, and I think that it's something that I've finally sort of come full circle and realized, yes, there's, good and bad. There's positives and negatives to any job. And there's really a lot to be said for a job that, at least in certain parts of it, is exactly like Nintendo, like that GI doctor.
Isn't it cool how things happen, though?
Absolutely.
Like, if you didn't do that little shadowing and have that
Yeah.
moment, it's like,
No.
It would have been maybe something, I'm sorry, it would have been
know
something
about
very different against your
No,
recommendation.
no. I tell my students, it's not, and I told him that the best thing that you do something that you like in order to be successful.
Right.
If you are doing anything, even if it's a great job, and you don't like it, you are not going to be successful, and your life will be miserable.
Yeah,
I
true.
really enjoyed what I'm doing. And that's why I was really successful. I was always nominated for awards, and and it's just like, I enjoy it. And the students say she cares. And some students told me the mom of pharmacy.
Yeah.
Just because I really care, and I really care and yell at them. It's not only.
That's great. A lot of wisdom.
I never got yelled at, of course. I haven't been yelled at like 6 times today. But she really cares, that's why.
Yeah, there's
What's
a lot of
the
wisdom
best
here.
piece of advice you can give as a mother when they're trying to guide their child?
To be honest with you, people, I'm Christian, people in the church, because he's a really good boy and he goes to church and he's,
Good boy.
really,
I am so glad you guys invited my mom on here. I'm so
and
disappointed.
people ask me what you did that you have such a son.
Can you imagine if you guys just waited 10 minutes for me to drop her off? If I had just dropped her off at the apartment like I planned, we would not get any of this.
I know, but as soon as I heard
this
this
is a very good
opportunity,
answer.
And then I
Go
told
ahead.
him,
Yeah.
I really
No,
don't remember anything. I think, thank God.
I couldn't pass up this opportunity at all.
I mean, it's going to be great for Bay Coast Bank.
No, they'll
I
appreciate
hope
it.
I'm not taking your stuff.
No.
No, they're loving this.
Because I think that in a way you definitely contributed to your success, and
So what I would say is that everything is perception, right? Like there's no actual reality. Like you can't walk it back and say, okay, Mena, like how much of your decision not to do an engineering undergrad was because of your parents' pressure, and how much of it was you kind of making the decision. And in retrospect, right, you're going through some hard years, right?
Mm-hmm.
There's a lot of self-doubt. There's a lot of, I don't know why I picked this, right? And
Right.
parents are an easy scapegoat, right? Like you're just waiting for the day.
Right.
Like my kids right now are 13, 11, and 9. And like every day, maybe not every day, but like anytime the topic comes up, I make sure to tell them, you can be whatever you want. You can do whatever you want, right? I'm sure that no matter what I do, at some point I'm going to be the scapegoat for some bad decision that they
Right.
made. Oh, you didn't tell me, or, oh, you didn't let me, or blah, blah, blah. So when I look back, right, I look back and, yeah, there's like a little bit of like, man, I wish. But, it's a experiment with no control group, right? And we tell that
Right.
with patients when they're having surgery, right? Yeah, we have all these studies, like 75% of the people do well. Guess what? If you're in that 25%, 100% of the people do poorly, right? Like if you have a bad result, it doesn't matter that most people have a good result,
Yeah.
right? If it's a
All that matters is what happens to you.
Exactly. If it's a surgery
Right.
with a 99% success rate, if you're in the 1%, guess what? It's a 100% poor outcome for you.
Right.
So I think, it's one of those things where I look back with a great deal of compassion that you can't go back and say, okay, well, what if, the decisions were made differently? Or what if, there was less encouragement or recommendations, right? How would that have turned out? Maybe it would have been worse, right? Maybe I wouldn't have had that sort of grounding. Maybe I need somebody to sort of
we
keep
never
me
know
in
the
check.
Well, you
Exactly.
clearly ended up in a field that you have a passion for.
Oh, I love it.
Obviously,
I love
it was
it.
the right decision. And I want to talk a little bit about the shoulder because
Yeah.
I'm, as a medical doctor, I'm always amazed at the shoulder joint.
Mm.
You know, you've got the knee. It's kind of simple. It's a little hinge, goes back and forth, right?
Don't like Dr. Smith here. So.
How did you
But then
pick
the shoulder, it's
shoulder?
like, it does so much, you know? It's this ball and
Right.
socket. It goes in every direction possible.
Yeah.
So much can go wrong. There's all these ligaments and
That's actually why I like the shoulder. So
Yeah.
to answer both of your questions, the reason I went into shoulder is because it's hard. And I think people with an engineering mindset are drawn to things that
Right.
are hard, and they want to take really complicated things and simplify them.
Yeah.
So
When
Yeah.
when did surgeons start specializing in, like, when did shoulder surgery
That's a good question.
become like
yeah,
a
well, instead of just general
specialty?
orthopedics, because
Yeah.
the shoulder is very specialized.
And I think what really made shoulder is the reverse shoulder replacement, which I think revolutionized shoulder surgery and took it from something that a lot of times we weren't really able to do much for. I think in the 70s and 80s when arthroscopy was being developed, I think that was a huge step for sports, right? So
Right.
there became a lot of sports surgeons that specialized in arthroscopy, but that was shoulder, that was knee. Eventually, it found itself into other joints. But I think before 2005, which was the first FDA-approved reverse shoulder replacement, if somebody had arthritis and a rotator cuff tear, there's really not much we could do. You could do an operation that could get them some pain relief and maybe a little bit of function, but realistically, once somebody has arthritis and a rotator cuff tear, they're really not going to be able to get much further than this.
Right.
And once the FDA approved this reverse shoulder replacement, which is basically when we take the socket and we put a ball where the socket goes, and then we take the ball on the arm bone side, and we remove the top of the ball, and it's now flat, and we put a socket there. So instead of the shoulder being a socket and ball joint that moves like this, it becomes a ball and socket joint that moves in the other direction.
And what's the benefit of that?
It compensates for the rotator cuff. You guys told me, but I didn't bring models. I should have brought the models. But it's
That's
something.
where you might come in.
It's my mistake.
Well, so I have like these little models that I show patients in the office, and you can just see, like, so the hip joint has what we call conformity, where the acetabulum, which is the socket, and the ball fits inside it like
Right.
this. It's really hard to dislocate your hip.
Yeah.
And all of the muscles around the hip, yes, they stabilize the hip joint, but they really mostly move the hip joint.
Right.
With the shoulder, the socket's kind of flat, and the ball really has a lot of mobility on the socket. And that's why with a normal shoulder, you're able to go in so many directions that no other joint in the body
It's
can
really
do.
an amazing joint.
It
I
really
mean, you
is.
can't really understate or overstate,
No.
I guess,
No.
how amazing the shoulder is.
Absolutely. And I think that I don't think a year goes by that I don't say, man, I know so much more than I did a year ago.
Mm-hmm.
And we've been doing these meetings with our local physical therapists that, we started with, just Primacare and Hawthorne and Clifton, but eventually it branched out to, 10 or more therapy offices in Southeast Mass. And, we learn from each other. Like, these guys teach me about the shoulder blade and how it's really underestimated the position of the shoulder blade and how it determines where the socket is, right? So if the socket is on the shoulder blade, this motion here is taking your socket and moving it in three-dimensional space. So if you're doing something like this and you're not paying attention to where your shoulder blade is in space,
Right.
then that socket is all over the place.
Right.
So
Is the shoulder prone to injury more than other joints, like the knee
mean,
or the hip,
It's like
or
a
or
worker
not?
joint.
So I think that it depends what people are doing.
Okay.
And I do think, and I tell this to my patients all the time when they come in, I don't want to be the reason that you're told that you can't do something.
Mm-hmm.
So if you come in and you say, I want to golf, or I want to do this, I want to do that, I think our job is not to question and say, you don't need to do that, right? Yes, maybe there are certain activities that are going to put the shoulder joint at more risk than other joints. And I think, eventually sometimes we have to have that conversation with people to be like, listen, like, your shoulder is not good enough to sustain this job. Like, I had a construction worker who had been jackhammering,
Oh my gosh.
and he had a dysplastic socket where the socket, he was just born with a malformation in the socket where instead of being flat like this, it was dysplastic and it was malformed. So the labrum, which is the O-ring that's around the socket, is supposed to be a nice thin structure that's, probably a little bit thinner than that pencil that's on your desk. Now, in his labrum, it was like this giant triangle because the body sort of compensates for the dysplastic bone, the bone that hasn't formed normally, by creating a labrum. And now he tore his labrum. Of course you tore your labrum. You have an abnormal shoulder that you were born with, and you're taking a jackhammer, and the force of the jackhammer is basically just pounding on that labrum. We had a conversation about, listen, like there's lots of things surgeons can do to you, but I don't know if there's much we can do for you. Right? Are we going to take your shoulder from being where it is to being reconstructed to like, oh yeah, now go jackhammer?
Right.
Probably not. So let's see what happens if we remove that from the equation. And if you can do something else, do it.
Right.
But, there's other things where people are worried that like, oh, because I have a rotator cuff tear, I can't play golf anymore. That's not true. There's a million things that we could do.
It sounds like there's a lot of conversation before decisions are made.
Absolutely. And that's actually, so the two reasons that I went into shoulder, one, it's complicated and it keeps my attention. Two, you actually have to like really listen to people, right? You have to like understand what it is that they want. And if you don't understand what they want, you can do things to them, right? You can say, well, this is what I like to do. Okay, what is it? Like, what does what you have to like to do have anything to do with this? What do I need?
Right.
And if you understand what people need, like what are their goals? I need to be able to sleep at night. I need to be able to put away dishes. Okay, we could do that.
And it's personalized. Like every
100%.
case is going to be different.
100%. Because if somebody wants to jackhammer, right? Maybe, right? There are certain situations where I look at it and I go, okay, well, you have a solvable enough problem, but here's what you have to go through. 6 weeks in a sling, doing nothing. 6 more weeks, no pushing, no pulling, no lifting. 3 months, no use of the shoulder. Full recovery could be a year, but at the end of the year, I think you might be able to go back to jackhammering, as taxing as that might be. Someone else, I might not be able to say that, but I need to know where the destination is.
Doctor, if you have two similar cases, do people prefer surgery over doing? It seems like they have maybe surgery in my mind, and I could be totally off. Sounds like it's a quick fix. I just go get it fixed, and you're going to do
there's
the
the
work.
rehab after.
Right, but if you don't have the surgery, I have to go do all this rehab anyway.
You have to do rehab either way.
So
Can I answer a different question that's going to answer your question? So the question that I never in a million years would have thought would have been a relevant question is, what's harder? Taking somebody who doesn't want an operation to tell them that they should get one,
right,
or somebody who doesn't want an operation and telling them that they should. I don't know if I just said the same thing twice, but you get the idea.
I get what you
Like somebody who doesn't to tell them they should,
I'm
or
going to
somebody
guess.
who does.
I think I know the answer to this
Tell
one.
me.
I think the harder thing is someone who is hell-bent on getting an operation and it's not the right thing, and you have to talk to them about that. Because I see those patients, and they always find another doctor who'll do that operation.
Never in a million years did I think that was going to be one of the hardest things in life. Because I'm not going to operate on somebody that I think, A, is not going to get better, or B, could potentially get worse.
Because people think surgery fixes everything.
Right.
And it's going to be less on them.
And I've learned over the years to try to frame it in different ways. One, if they have a rotator cuff problem, which hasn't been treated conservatively, which for a lot of people, like if somebody's 72 years old and still very active and still wants to do a lot of things, but no injury, no specific time zero, just insidious onset pain for years, and I don't get an MRI in that patient. I wait, because if you tell me that they have a rotator cuff tear, I say, yeah, they probably do. 20% of people at age 60 have a rotator cuff tear that they don't know anything about.
Oh.
So by the time you get to 72, you got a decent chance of having a rotator cuff tear that you just don't know is there. So for us to discover it on MRI doesn't explain your shoulder pain because you've had that thing for years.
That's a really good point. I never thought of it like
I mean, you
that.
see a lot on MRI that looks horrible, and people function and they do fine, and they don't always
Absolutely.
have pain.
And if we were treating MRIs, then we shouldn't see the patients in the office.
I'll give you an example, a personal example. So I had a cervical disc herniation, right? So I had a cervical radiculopathy, terrible pain down my arm, a little bit of weakness in my hand. So I had an MRI done, and the radiologist calls me, and he says, "You have to have surgery today. It's horrible. It's horrible. You got to have surgery today. You can't even wait a week." I said, "I'm not going to go for surgery today."
No.
So I went for, physical therapy and took some steroids and did the usual stuff, and, it got better over like 2 months.
So
and it was complete. It's completely resolved now.
So the data on cervical discs and lumbar discs is that if it's going to get better, it's going to get better within 6 weeks.
Yeah.
Now,
And that's exactly what happened.
exactly. So can you, for whatever reason, like if you have myelopathy, which is like compression of the cord, or a bad enough compression that, and obviously I'm talking outside of my field, like this is something that a neck specialist or a back specialist should be advising people. But there are situations where people have severe symptoms like that, and within 6 weeks it's completely gone. Are there situations where a surgeon might tell you there's a good reason to intervene sooner?
Sure.
Yes, right? But the people that should be deciding that are the people with skin in the game.
Right.
The person that is getting the operation or the person that's doing the operation.
Yeah, and I guess my point is I don't think you can make a decision about whether or not someone necessarily needs surgery from just one piece of data.
Absolutely.
The MRI. You've got to look at the whole picture. So, and of course, anyone who's listening out there, do not look at my situation and apply it to yourself.
Right.
And just say, well, I'm not going to listen to some advice to have surgery, because you may be in a very different scenario.
Exactly. And that's why I was hedging it a bit, because I can see a patient with a full thickness rotator cuff tear, and I'll tell them, like, listen, like I think your most conservative treatment is surgery.
Yep.
Right? The 58-year-old manual laborer, otherwise healthy, non-smoker, non-diabetic, had an injury 3 weeks ago that's, classic for a rotator cuff injury, where I was grabbing, and then I immediately felt a rip in my shoulder, immediate pain, and ever since then I haven't been able to raise my arm. I can get it up here eventually, but, it's been bothering me. I haven't slept since the time of the injury. That conversation is going to be, okay, my friend, I'm going to send you for an MRI. Your MRI is going to show a rotator cuff tear. You're going to come back, and between now and then, I want you to wrap your head around the idea of having surgery. Now, is the surgery going to be easy? No, it's going to be very painful. Is it going to be fun? No. You're going to be 6 weeks in a sling doing nothing, 6 more weeks, no pushing, no pulling, no lifting, 3 months, no use of your arm, to go back to your construction job. Even if you're doing perfectly well, I'm not going to let you go back until 6 months after surgery. I've had construction workers beg me at 4 months, please, 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 my shoulder is perfect. I'm like, you need my signature to go back to work. You're not getting it till 6 months.
Is there a time limit from injury to surgery? Like, suppose someone waits like 3 months thinking hopefully it will get better.
So with an acute injury where we have a time zero, I consider that like a completely different animal.
Okay.
Right? So when we're dealing with something that, who knows when this, like the 72-year-old who's had a month, 2 months of shoulder pain and a rotator cuff that's huge, like a huge tear. And I'm like, there's no way this happened 2 months ago, right? This has been brewing for years. For that one, slow it down, conservative. Let's see how you do. Just like with Dr. Jonkus, 6 weeks of therapy. See how you're improving. If you're getting better, great. Not improving, different conversation.
Right.
With an acute injury, the further away we get from that time zero, the more scarring you get, the less mobility you have of the tendon. And I'll tell people sometimes, I'll look at the MRI because, we read our own pictures. Like, we're not, looking at the report, we're looking at the pictures. And I'll show patients and I'll be like, okay, you see this tendon that's all the way over here? That belongs all the way over here. And the longer it sits here, the harder it's going to be to get it over here. Some of them are torn but not retracted, right? So if the tendon belongs here and it's all the way over here, that's a different story than if it's torn and it's just like this. So these are more urgent, and the bigger the tear, the more urgent it is.
So if it's retracted, it's like you have two pieces of string you're trying to connect and you just can't do it.
Right.
It's not there. The
Where's
tissue
the
isn't
point
there.
of no return with a tear? Like when it, like, is it like, okay, more than 50% tear, you have to have surgery? Is there any rule like that?
So I share a lot of patients with one of my colleagues up at Mass General. He used to be at Mayo Clinic, and he moved over, I think a year and a half, maybe 2 years ago, to Mass General. His name is Bassem Al Hassan. Phenomenal guy. He has pushed the envelope to what we would consider the point of no return by inventing these tendon transfers. So if anybody who's listening is a physical therapist or an allied health professional or somebody or anybody that is just interested in coming, we're doing a course together here at the PCI Institute at the cadaver lab here, where he's demonstrating these tendon transfers that he's invented.
Oh, nice.
And it's something that if I am going into an operation and I think somebody's rotator cuff might not be repairable, and it is one of these high-stakes situations where it's not something that the patient's going to be able to, like a 55-year-old manual laborer, previously had a rotator cuff repair at 50, re-injured it. Now we're going in there trying to fix it a second time. You look on the MRI, they already have a little bit of atrophy. So
Right.
that muscle, if you think about the muscle is the engine, and the tendon that connects the engine to what it's trying to pull on, right? So the muscle is attached to the bone through the tendon. So basically when the tendon tears, even if the muscle is working, the tendon is not able to transmit the
Right.
force to the bone, right?
Right.
So if the engine itself is dead, if the muscle is dead, then that we consider that to be a non-fixable tear. So if somebody doesn't have like complete atrophy, but some early atrophy, and we say, okay, well, you've got these factors against you, and your history of prior surgery, and how big this tear is, and that early atrophy, I might be able to fix it, I might not. So in that case, we'll have two conversations. One, here's what I'll do if I'm able to fix it. Here's what I'll do if I can't fix it.
Yeah.
I can see how your love of engineering fits into this field so
absolutely.
perfectly.
Yeah.
You know, just hearing you talk with such passion.
Absolutely.
What are the more common shoulder injuries that people incur?
So I think one of the most painful, miserable, life-changing things that people get is a frozen shoulder.
Mm-hmm. I see that a lot.
And what is that exactly?
So I think I'm mentioning this because it's so common and it's
It
so
is.
miserable.
It is.
And people are so convinced of two things that are opposite extremes that are not true. One is, well, they wouldn't do anything about it anyway.
Huh?
Or there's nothing that they can do about it.
And there's so much we can do
Right?
for that.
It's treatable, right? You can fix it, and it's not going to go away by itself.
Right.
If yes, eventually. Actually, I saw one of our partners years back, and I said, okay, here's what you got is a frozen shoulder. He's like, what's that? And I said, well, it's inflammation of the capsule, which is the pocket around the ball and socket joint. And when the capsule itself gets inflamed, it basically mimics arthritis. So arthritis is when the ball and socket joint breaks down, and instead of having that nice cushion, and like you look at an x-ray and you see a nice space between the two bones are,
It's like bone on bone.
right? So that's arthritis, right? So if somebody doesn't have arthritis, they have a normal x-ray and they have a nice space between the two bones, and the exam looks exactly the same as arthritis, and that exam is a universal loss of range of motion. It's not like a rotator cuff tear where like, oh, I can't pick up my arm, but with help I can get there. That's a rotator cuff tear exam. Or somebody who has some kind of pain inhibition in the shoulder related to the rotator cuff, where it's like, oh, no, please don't do that. Please don't do that. Oh, it hurts so much. But at waist level, that patient's going to have symmetric external rotation. Right? So the rotator cuff is not going to affect your passive external rotation. You can have a rotator cuff tear that affects your active external rotation because one of the rotator cuff muscles is the one that helps you to get your arm out in space. But you can have the biggest rotator cuff tear in the world, and if I sit with you gently in the office and I hold you by the hand and I bring your arm out here, you're going to be able to get your arms out symmetrically out here. You might not be able to hold it there. Like once I let go, your arm might come back to your belly. It's still going to be able to get there passively with my help. So if somebody has a global loss of range of motion and they're not able to raise their arm, they're not able to let me bring their arm away from their body, at that point I'll tell them, so your normal arm, you're not going to be able to get the same way with your affected arm, because the normal arm you're going to be able to get to the middle of your back, and this one I bet you're not going to be able to get past your back pocket. And they're like, yeah, how'd you know? I was like, okay, it's not my first day, right? So once you see this and once you see this, how are they going to be able to get behind their back? Because this is the forward elevation, this is the external rotation, this is the internal rotation, right? And if the capsule or the ball and socket joint, if either one of them are the place where you can localize the problem, they're not going to be able to do any of those things. So just with a simple x-ray, you look at it and you say, okay, they don't have arthritis, they have this exam, that's a frozen shoulder.
So tell our audience a little bit how you get a frozen shoulder. That'd be an interesting point to understand.
We have to distinguish a frozen shoulder that just happens versus a frozen shoulder that happens for a reason. So if I put somebody in a sling for 6 weeks after their rotator cuff repair and they're still stiff at 3 months after surgery, is their shoulder frozen? Yes. Is that a frozen shoulder? No. Is that adhesive capsulitis? No. They have a stiff shoulder from being immobilized and from having the rotator cuff repair. We induced that frozen shoulder. We did that on purpose, right? Because the healing is something that we prioritize for the first 6 to 12 weeks. And the flexibility is something we can get to later, right? There was actually a study of Mount Sinai in New York that said that people who have stiffness at 3 months after their rotator cuff repair have the same range of motion at 1 year, so they eventually get their motion back, and they have a higher healing potential than the people who had normal motion. So the stiffness early on is actually protective, right?
Okay,
and that's completely different than somebody that just woke up one day and they're like, I can't move my arm. The people that are prone to that are people who are diabetic, people with thyroid problems. It's a demographic. But if somebody doesn't have any of the risk factors and they just have an exam that's consistent with adhesive capsulitis and a normal X-ray, it's a clinical diagnosis. You don't need the MRI. You don't need, anything fancy. You can talk to the patient in the office and just say, listen, you can't do this. You can't do this. You can't do this. And it's not pain inhibition, right? Because even the patient with the worst rotator cuff tear, the worst rotator cuff pain, will still let you gently, cautiously, kindly, patiently get them to a symmetric external rotation.
I'm always amazed that with patients with a real bad frozen shoulder, you literally cannot physically move the arm at the shoulder and above maybe here.
Nope.
It's remarkable.
They can't go here. They I had a guy today who couldn't get past neutral, right? And they cheat and they compensate, right? Because if you abduct, right? If you bring your arm away from your body, it looks like you're externally rotating. That's not external rotation. That's abduction. So they're functional, right? They're able to get through the day because the shoulder is so remarkable that it can compensate for so many things. You can lose most of your shoulder motion and still be able to move your hand in space and get through the day.
So the diagnosis, it's mostly clinical exam and maybe an X-ray, but you don't need an MRI or anything like that.
I get an X-ray just as a matter of routine.
Yeah.
Anybody over 50. And I'll tell you, one of my favorite patients is the one that taught me never, never, never underestimate how bad somebody's arthritis can be.
Yeah.
And this is one of my favorite patients of all time. I've treated like 3 or 4 different joints on him. And he's so active and he's so muscular and he's so fit and he's got such great range of motion that I was like, okay, there's no way he has arthritis, right? Like there's no way. And he's early on enough in my career that I didn't get routine x-rays, like if their range of motion was pretty good, I'd just get the MRI. His MRI comes back and I'm like, how much arthritis is this guy walking around with? I'm like, can we get an X-ray? Because the X-ray is better actually at looking at the bone and looking at the space between the two bones. He goes for an X-ray. You guys got bone-on-bone arthritis.
Mm.
And I told him, I was like, okay. I'm like, let's retrace our steps. I'm like, I don't think I would have done anything differently, so I don't think we've wasted any time. I just feel really dumb that I didn't pick this up sooner. But I told him, I said, and he came back for his follow-up, like I think for something else. And I was like, ever since that day with you,
Right.
anybody over 50 gets a routine set of X-rays.
Well, it kind of goes back to what we were talking about before, where you can't make a diagnosis necessarily of how severe someone's pain is based on a study, a radiological study. So, I see it all the time where I do an MRI because someone has, severe back pain that seems fairly intractable and whatnot, and maybe they have some pain going down their leg or whatnot, and they have really nothing going on. And then I do another one. Someone has, symptoms that maybe it's less severe, but they have horrible disease. It's really fascinating to me how the human body can adapt and react differently to injury.
Absolutely.
So, but it sounds like for frozen shoulder, an X-ray is mostly
Very
what you
reasonable.
need.
Yeah. And there's a difference between a working diagnosis and I'm the doctor and I said so.
Yeah.
Right? There's a difference between, okay, 55-year-old atraumatic, insidious onset shoulder pain, just kind of getting worse over time and, no treatment. Or maybe, they went on a course of oral anti-inflammatories or oral steroids even because a frozen shoulder, not just in my opinion, but like the data shows that it doesn't really respond well to oral treatments. Like an oral anti-inflammatory, even as strong as prednisone, tends to give it relief for a few weeks, and then the inflammation comes back. There's just too much inflammation.
So how do you treat it? What do you do?
So I like to use an ultrasound machine to make sure that we get the injection right into the ball and socket joint with a numbing medicine. So that way we get two checks. One, seeing it with the ultrasound machine, making sure that needle goes right into the ball and socket joint. And two, I'll have the patient, hang out for about 5-10 minutes. And then within 10 minutes, they're like, I can't believe it. Like my pain is completely gone.
Yeah.
And that confirms for us. It tells us, okay, we got the injection in the right place. And then, the numbing medication wears off, and the cortisone takes about a week to kick in. So, yeah, I think not every patient needs that. And, I've got, a little chart on our website. So on primacareortho.com, we've got, different modules. And one of them is frozen shoulder. And you can see that there's an inflammatory phase, there's a frozen phase, and then there's a thawing phase. And in that inflammatory phase, the shoulder's getting worse and worse and worse with time. Once someone gets to the frozen phase, sometimes it's not that painful, right? Oh, yeah, I've had this shoulder problem for 9 months. Is it painful? No, it was painful. Now I just can't move it.
Yeah, right.
What about those 4 to 6 months that you couldn't sleep at night? He's like, I thought it would go away. It's like, well, I think if you saw me a month after this started, the cortisone injection would have helped you a lot. It would have brought that inflammation down much sooner. And instead of going all the way up that slope to get to the frozen phase, we could have gotten to that frozen phase much sooner or not at all.
We've talked about this before too on other shows. Like people, they create that tolerance for themselves,
Sure,
and they're not gonna go seek treatment until it becomes almost unbearable.
Yeah, some people and people have different pain thresholds and different thoughts about interventions and whatnot. But how about physical therapy for that?
So
does that
I
help?
think it depends on how they respond to the lidocaine component. So if somebody, comes in, let's say 4 weeks, right? They've had 4 weeks of symptoms, and in a very, very, very short amount of time, in 4 weeks, people can get to, I can't move at all. But why, right? Is that the same? It's the same exam as somebody who's had 6 months of symptoms.
Right.
But the person who's only had a month of symptoms, all of that is pain inhibition and the inflammation keeping them from being able to move and the pain keeping them from being able to move. But it hasn't started yet with that organized fibrosis. So Jo Hannafin is a tremendous surgeon. She's at Hospital Special Surgery in New York, and she did these incredible studies with Dr. Naviser, who's one of our colleagues there, and they did biopsies arthroscopically. And what they found was the tissue itself over the course of the disease process changes, and it goes from an inflammatory picture to a fibrotic picture. So once someone gets to fibrosis, it's not that painful. It just doesn't move. Physical therapy will work with them on stretching exercises and getting their flexibility back. I think years back, and I think that's still done in very, very select cases, but it's not some. I think I've done this. I think I did it once, and I had a very, very specific reason for that patient not to have surgery. And we did what's called the manipulation, where you put them under anesthesia and you move their arm. In the shoulder world, we tend to get a little squeamish about that because what's happening, like what's tearing in the shoulder. It's not just going to be the capsule. You know, you can tear somebody's rotator cuff. You can tear, you know, all sorts of things that you're not trying to tear.
I think I used to see more of that done in the past than I do now. I have had patients in the past go for go for manipulation and anesthesia, and I haven't seen that in years. It sounds so brutal.
So I get the idea, like, well, if you can't move it, I'll move it for you. But that sounds like, you know, if you can't do this, then I'll show you. And it's like, no, like, I think a lot of people, first of all, will come in with pain. They will come in the freezing phase. They will respond well to the cortisone injection. And if in the office, the range of motion comes back completely, right? That's probably the patient that's only had 4 to 6 weeks of symptoms, hasn't had a lot of fibrosis, in which case I send them to physical therapy, not because I think they're going to be there for a long time, but, you know, just learn an exercise program, have at it, and you'll get better. The people that are either in the frozen phase already or far enough along that even when we give them the cortisone injection, it takes away their inflammation, but they still have enough limitation, I'll be able to tell them in the office, listen, you have no pain. No, you still can't move though, right? It's still stuck, right? That's not the pain that's keeping you from being able to move. That's the fibrosis. And that the physical therapists, I think, have a lot to offer the patients, you know, tracking them, encouraging them, checking in with them, making sure that they're doing their stretching exercises, gentle stretching in the office for the people that maybe are not so keen on doing their stretches at home. I don't think it's a substitute for it, but it's, you know, it's better. It's something. It's better than nothing. I'd rather people be consistent with their stretches at home, but if they're not going to stretch at home, at least they're getting some stretching in the office from the therapist.
How important is it to do stretching before, like, you're playing golf or tennis or something like that?
It depends on the patient. I think, you know, there are people whose shoulders are naturally so flexible that stretching is probably a non-issue for them. I'm one of those people. So most people can't raise their, this is, you know, an abnormal amount of elevation. Most people can't get past here. Same with external rotation. Most people can't get past here. People with extra flexible shoulders are able to externally rotate that much. Most people can't abduct past here. This is hyper-abduction.
How far can you go, Nancy? Let's test it out. Let's see.
All right, let me do the up. That's my up.
So you're doing two things.
Okay,
so
what am I doing?
So now you've got three. Do you see how you turned?
Yes.
Right? So when you turned towards my mom, right, you brought your thoracic spine, which is your back, outside of that rotation, right? Because you want it to be like me. You want it to be cool like me.
I know, I did.
I'm not cheating like you are,
was
right?
Cool? He wasn't a cool kid, was he?
No, never.
A little nerdy, maybe.
Actually, they still tell me in the OR, like, blah, 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 back to the nerd table. I'm like, no, I want to be with the cool kids. So they know that I never sat at the cool kid table, ever.
You seem like you were cool.
No. Yes, I mean, of course. My mom's the coolest.
Right.
I'm not. I know myself.
All right.
What can you do?
So, just look at the forward elevation, right?
Yeah.
So
I can go up like that high.
Right? So this is where most people live, right? Yeah. And now, without doing this, which is what you did.
I know, I cheated.
Right? Without turning your back, right? If you're able to go from this position to this position, that is hyperflexibility. If you're able to go from...
Can you do that?
I don't know. Am I doing it? I'm not sure.
Let me see. So sit forward for me. Yeah. I mean, you're like 175. You're not quite 180, but you're close. Let me see how far this way. So you see how you can get just barely past 90?
Mm-hmm.
So most people are here.
Okay.
There's a French guy named Gagé. So when people are able to hyperabduct, we call that a positive Gagé test. So I would say you're a, soft positive. And then external rotation. Oh, yeah. You see that? You see how, so if you lean forward, you see how my hand is on your back and our forearms are flush with each other?
Right.
That's 90 degrees of external rotation. And maybe not now, but at some point, you were able to look, like I can't do this anymore, but there was a time where I was able to hook my hands
I don't think
together.
I can do that anymore.
Yeah,
No.
but we used to be able to
you,
do
man,
that.
You got a big
Right?
gap there.
There was a day where our hyper flexible shoulders meant that we could hook our hands like that. Those people, right, instead of stretching, they want to strengthen, right? Because think of the shoulder as an ecosystem, as a balance, right? If your shoulders are tight, you want to stretch. If your shoulders are flexible, you want to strengthen.
Oh.
Interesting.
Again,
Wow.
the engineering.
So we talked a lot about frozen shoulders. What's the next most common thing you see? Would it be rotator cuff tears or tendinitis or?
So I think in my practice, probably the most common things are people on that rotator cuff spectrum, which, like we've talked about, the severity of illness does not predict the severity of symptoms, right? Somebody can have a completely terrible, trashed rotator cuff that looks like a bomb went off in there, and I actually feel pretty good, doc. And you're like, how are you even moving your arm, right?
Right.
Actually, one of my most interesting patients came after years of bodybuilding. I love this guy. He's one of my favorite patients, and he has such a bad shoulder from all of the bodybuilding work that he did. And he was another one that surprised me. And I had a clinical diagnosis for him of AC joint arthritis, which is arthritis in the bone between the collarbone and the shoulder blade. So this is the acromion here. This is the clavicle here. So the AC joint is right there. And that's where all his pain was coming from. He didn't have any pain in the shoulder, nothing that looked like a rotator cuff problem or a shoulder problem. Full range of motion, full strength. This guy was a strong guy, right? So I gave him a cortisone shot into the AC joint. His pain went away completely for a month or two. Great, problem solved. Like, what else do you need to know? Like, symptomatic AC joint arthritis on X-ray, relief from the AC joint injection. Like, that's a open and shut case. Pain came back. Okay, well, what are we gonna do? Well, no. We talked about surgery. Okay, well, if you think that'll help me, let's do it. So I sent him for an MRI. Comes back, his entire rotator cuff is torn. Everything's gone. Everything's gone. So the subscap in the front, gone. Supraspinatus in the top, gone. Infraspinatus in the back, gone. Everything completely torn. I told him, I was like, I'm like replaying it in my head. I'm like, could we have done anything differently? I'm like, no, like symptomatic AC joint arthritis. I'm not gonna, what am I gonna do? I'm gonna operate on the guy's rotator cuff because his AC joint hurts? I'm like, that wouldn't have made any sense. I was like, all right, listen, here's what I'm seeing. And I told him, I was like, I think this rotator cuff tear has been there forever. I don't think it's fixable. I think we go in for surgery. If I happen to be able to fix your rotator cuff, I will. I don't think I will. I'll try. I'm not going to say I won't. I'm just going to say I'm going to try. But I think the main reason we do the operation is to get rid of the arthritis in your AC joint. And all we do there is we just remove about a centimeter of bone, open up that space. So I went in, and as expected, the rotator cuff is completely like just a bald head. And, there's some tricks and things that we do to try to get the rotator cuff to be more mobile, and, it's scarred in. It's been there for years. But, I spent like maybe an hour just trying to get this thing to mobilize.
Right.
Nothing. Did the AC joint, right? Got rid of the arthritis in the clavicle. After surgery, he was devastated. He's so upset. Why didn't you fix my rotator cuff? I'm like, well, I don't think that was part of your recent injury. I don't think that's where your pain was coming from. I think you've been living with that for years. And he's like, oh, but what if I don't get better? I'm like, listen, time will tell. We have to see how you do with the rehab. Ends up with a perfect result, right? He ends up with a completely back to baseline, great strength. You know, like it's not like it was when he was 35, right? The first time he probably like blew it out.
But how
Happen,
can
though?
he
That's
have-
like
I
a
don't
full
know.
How can he have
tear.
strength and range of
don't
motion with
know.
a torn cuff?
I don't know. I don't know. So Bill Mallon is the former editor of the Journal of Shoulder and Elbow Surgery. So is one of the smartest guys in orthopedics. He was the editor-in-chief of that journal for, I don't know, like 30 years or something like that. The New England Shoulder and Elbow Surgeons invited him to be the guest speaker. He's going to talk about rotator cuffs. Awesome. I think I was like 2 years in practice. I was like, I've never been so confused in my entire life. Like people come in, like the
Right.
pathology and the symptoms do not add up. Like he's going to tell us like how to figure out why people can come in with huge tears that are asymptomatic and people with tiny tears that not only are symptomatic, but when we fix the rotator cuff, they feel better. So it's not like,
Right.
you know, like there's like this, like, you know, looks like the
Subjective.
quacks,
Yeah.
like there's like,
Yeah.
it makes sense. Like we treat it and it gets better. So like, it's not like we're making things up, right? What is the first thing that Bill Mallon says? He gets up there, he goes, I don't know. Like the first slide was, the rotator cuff makes no sense. And I'm like, great. Like we
That
drove,
would be frustrating to me because
all-
I'd like want to know. Like there has to be something.
if that's the goal is to know, then we can sometimes succeed and sometimes fail. And I don't say this to be corny, but if our goal is to take care of people, we can always succeed. We can take care of them
Very well said.
without knowing, right? We don't need to know. And the patients want to know. And I'm like, I don't know. And they're like, don't you care? I'm like, I care, but knowing doesn't help me care. I just had a patient today. Listen, I see your x-ray. On your x-ray, which is subtle, and I showed the patient the x-ray. I said, you see how here you've got these little bubbles and this irregularity? This was read as a normal x-ray. But you see that right there? That, with your exam, right? So she had a, you know, pretty classic
Yeah, yeah.
standard rotator cuff exam. Like, I'm like, my guess is that if you got an MRI today, it would show a rotator cuff tear. What are we going to do about it? Are we going to fix it? No. Let's treat it conservatively. Anti-inflammatory, so long-acting, not a short-acting.
Right,
So
right.
not ibuprofen, not, you know, anything that's going to leave your system in 4 to 6 hours, but something that's going to stay in your system. Naproxen's in your system for 12 hours. Meloxicam's in your system for 24 hours. So if you take naproxen twice a day or meloxicam once a day, that'll help to bring down the inflammation, settle down this episode of pain. Go to physical therapy. You'll do the same exercises that people do after they finish their rotator
Right.
cuff rehab.
Right.
So instead of having your rotator cuff repair and then 3 months later, 4 months later, starting with this rehab, you get to jump the
Go right
line.
in.
You go right in. You do those exercises.
Right.
You get better. Who cares what your MRI shows?
I guess it's human nature, right? We always want to know. We want to know underlying what's going on inside of us, and that's always a difficult thing for patients. And I see this a lot. So I'm going to use the back issue. I see low back pain all the time.
Yeah.
I see patients, they don't really have much going on neurologically. They haven't had it for that long. They haven't tried conservative therapy, and they want the MRI.
Yep. Yep.
And there's actually some danger to getting an MRI because you get it, and now you find this stuff there that looks really bad.
Right.
But I know without an MRI that these people are going to get better most of the time.
Yep.
But now they have an MRI that shows all this stuff that, now they want to go see a neurosurgeon, and hopefully they go to see a reasonable neurosurgeon. But
Which we're lucky in our
and
area.
we have good neurosurgeons.
We have great
here.
neurosurgeons with very
But-
tight, very good indications.
But some of those patients end up having surgery when they don't need it. And not here necessarily, but it's happened,
Yeah.
I mean, there's, I'm not trying to be critical. But,
or when you get an imaging study to look at somebody's gallbladder and you find something on the liver.
Right,
And now you've got this liver lesion that you don't know what to do with. Do you want to do a biopsy?
right.
Okay, so now we biopsy the liver lesion that we didn't know was there,
Right.
that we only found because we were looking at the gallbladder, and now we have a complication from the liver biopsy.
So it's these incidental findings that can drive you crazy in medicine.
So why get the study in the first place?
That's my point. It can
right?
be actually be dangerous
Exactly.
because you see something, you chase your tail going after this. It ends up in another study, maybe a biopsy down the road, and it's all nothing. But the patient now has gone through all this pain, and
Right. And we
angst.
as physicians feel like we're bound to do that.
Right.
Right? We feel like I owe it to the patient, and sometimes we have to step back from that. Like, what do we owe them? We owe them that if this was our family member sitting here,
Right.
we would do what's reasonable, and we explain that to them. If after we've explained to them what we think is reasonable, they still want the MRI, then a lot of times I'll just get it.
And
Right.
you know, I as a physician, I have the conversation.
Exactly.
And you know, ultimately, sometimes you do what the patient wants because they need to have that information, but it's not always good. And it's interesting in America, of course, we rely a lot on technology, but other countries that have more, let's say, socialized medicine, where there's we're really going a far afield with this, but
Yeah.
they rely more on physical exam techniques and all that. And,
Yeah.
you know,
And I think in the shoulder, and the other field that I actually really like for the same reason, because of the same difficulty and the same, like, you need to pay attention and you need to,
Right.
you know, actually listen to people, is spine.
Yeah.
Of
So that's
course.
come up
Yes.
quite a bit, because if you're just treating the MRI in shoulder, you're just treating the MRI in spine, you're going to miss so much.
Right.
Right? It's critical that you ask, is what I'm seeing on this side of the room matching up with what I'm seeing on this side of the room? Right? If everything matches, great, we get more confirmation. If there's something off, we need a tiebreaker. We need to we need something to tell us, okay, this says this and this says that. And you know, I'm very, you know, upfront with people. I tell them, like, listen, your situation doesn't make sense.
Well, I love your approach to how you basically evaluate these patients. It's one of the reasons I wanted to have you on the show, because I
Appreciate
think
that.
you do a great job at evaluating a lot of the, you know, all the common shoulder problems that we see and some of the less common shoulder problems that we see too. So thank you. I appreciate you coming. I appreciate your mom coming on too. This was great. It was great having
And,
you.
you know,
for having
We learned a lot about a lot of, you know.
So your
About med- yeah.
last thing about curiosity, like,
Yeah.
people are curious. So before we started recording, we started to tell you the story of how curious I was as a kid.
Right.
And my mom was about to tell you guys that, like, if I hadn't specifically been told not to do something,
Okay.
I was allowed to do it. Anything that was, like, on the blacklist,
Not on the list.
I'm like, they're like, what made you think you could do that? I'm like, you never told me not to do that.
Right.
And they're like, okay, this is one of the things you're not allowed to do. And one of my
to the list.
add it to the list. One of my favorite things that was not on the list was when we were in Vienna. And my parents, do you want to tell the story? Or do you want me to
No,
tell
you
it?
tell it. You remember better than me.
I was 3 years old.
I know
only
he was
know it
3
because
years old. And we were in a department store,
Right.
and there was an escalator. And we were just looking around. He was with us. Of course, he didn't stay. He wandered around. There was a red button, tick, and the alarm.
Oh, the alarm.
So the escalator had a
That's
red
great.
button, and I was not told not to push the red
You
button.
weren't told not to.
And you know, like those, like, earliest
Sure,
memories
sure.
that you have.
Yeah.
I still remember looking up and all of these, like, very unhappy people looking down at me from the escalator, and I'm like, and the alarm's going off. I'm like, did I do that?
So that's an old memory. Let's kind of ask you about a more recent memory, like an anniversary memory.
Anniversary.
So I believe we talked about your mom, who joined us here today.
Yeah.
You mentioned your kids. We haven't really talked about your wife. And
Oh no, you're not going to bring this up.
So did you hear the story?
I hear Tyler
Mom?
laughing from the other room.
Did he share?
She
with
doesn't
you?
know this story.
I don't know
I-
anything about
I thought we
that.
were going to keep it to things that she knew about.
Oh, so this
I
is
don't know
very
anything
interesting.
Now,
about
speaking
that.
to
I
the
guess
mic.
this wasn't on the list. I guess this wasn't on the list either. So go ahead. Let's share this story.
What story are we sharing?
Oh God. So, Dr. Jonkins, like, so you guys know how I said, like, I believe in radical transparency,
Yes.
and you know, I don't feel like I want to hold anything back. I am so impressed with Nancy that she was able to bring the envelope right up against that line. You haven't crossed the line. Like I
Okay.
said, I don't think I really have a line. I'll tell you anything. But before I tell you the story, I just want you to understand, like, we've got, like, at least part of that pinky toe over that line.
Oh,
right?
Oh,
This-
boy.
This is like,
Well, might as well put the whole foot over.
oh yeah,
So,
like this is like, you know, like the tennis matches where
Yeah.
they've got, like, the ball tracker.
Yeah.
inappropriateness, like what do I really want to talk about
hit
in a
the
public?
line.
We might have to break this off and put it into our little separate show
for like our
the patrons. But
patrons.
we'll hear the story first.
This is like people.
This is
You're gonna get a
patron
lot more than
content.
$5 a month for this one. All right. So every year, I can't believe it. Tyler, you're in so much trouble. So every year, I plan an anniversary gift for my wife.
Okay.
And every year I look up, what's the anniversary gift? And the first year is paper, the second year is whatever, and every year has like a traditional
sure.
present
Of course.
theme. So I
can only imagine where this is going.
I've done it every year, and I get to year 16 and it's wax.
Wax. Oh.
Like,
Wax.
what's what's made of
isn't
wax?
on the list, FYI.
Wax candles. I'm like, okay, I'm gonna get her a candle. Happy anniversary. Like, I'm not gonna get her a candle. It's like, I don't know, and I can't think of anything. And I'm talking to Tyler, so I'm here. We have an event, and I'm like, I can't.
Tyler's our engineer, just in case.
Yeah.
Tyler's our producer.
He's doing all the work back there.
He's our magic man.
Tyler's
great,
my
but we can't see
ex-friend.
him. He's in the background.
I used to like Tyler a lot. So I'm talking to Tyler, and I'm like, I don't know what I'm gonna do. And he goes, there's one thing that's like obvious. I'm like, yeah, I thought of that, but like, I'm not gonna go for a full body waxing like that. Like that's not gonna happen. And Tyler goes, well, what if you just did your chest, and what if you just did a heart? And I'm like, oh,
Look at our face.
that's genius. And we had some visiting surgeons, actually, Dr. Kwan, who's a professor of shoulder surgery at NYU. And he was a visiting professor, and he was, doing a lab with us here. And I was like, Dr. Kwan, what do you think? And he goes, I don't know. Like, I wouldn't do that. I'm like, I know. The question is, would you do that? Would I do that? And he goes, you probably would. And I'm like, all right, let me think about it. And like, the more I thought about it, the more I'm like, no, I'm definitely doing this.
That's so sweet.
And the only question left was, do I bring her to the place, or do I just get it done? So I stopped by a place. I went to Patriot Place. There's a European Wax Center, so maybe they'll sponsor you guys. So European Wax Center, very, very nice people, very awesome. And I walk in, and I tell them, I'm like, never had a wax before. It's my 16th wedding anniversary, and I want to get a heart. And they were like, are you joking? I was like, no. I wish I was joking. I'm actually very serious. So the only question is, do I bring my wife here later, or should I get it done now and just surprise her? And, the manager tells me, we've got a girl who specializes in this, but she gets off at 5 o'clock. So if you're coming back for dinner, she'll be gone. I was like, oh, other people get this? She goes, strippers usually. And I was like, okay, all right. So if shoulder surgery doesn't work out, I've got another line of work. Excellent. So
well, you've got that flexibility.
Absolutely. And the audacity, right? Like the no filter, like whatever. So I get so I've got a video of the chest waxing, and I go home. And I picked up 2 candles, one pink, one sage. Our wedding colors were pink and sage. So I've got a video. My daughter's taking a video of me giving my wife the candles. And she's like, oh, wax, that's so nice. I looked it up, and I got you a candle. I'm like, oh, thank you. And then I was like, I got you this card. And the card had like a wax seal on it, right? Because we went to Italy some years back, and we got a wax seal with an M, like the family logo.
Yeah.
Like, wax seal. And she's and I was like, there's one more present. And she's like, what is it? I'm like, what do you think it is? And she goes, I don't know. Are we going to a wax museum? I'm like, no. She's like, are we going somewhere that has wax in the name? I'm like, no, I already went. And she goes, oh. What? And I take my shirt off and I go, happy anniversary!
You should have ripped it off like Superman.
I like that shirt, actually. So she's like, oh my God! She's like, are you crazy? She's like, I know you're crazy, but like, what did you do? I'm like, touch it. So I sent Tyler the video, and Tyler's favorite part was when she goes, are you crazy? And I go, touch it. I had a heart in my chest. And the next day I was doing a triathlon, or like the following Saturday. So I realized, I'm like, oh my God, I got this wax chest and I'm going to go for the swim and I have to take my shirt off for the swim.
Sure.
So the director of the triathlon, the woman that's coordinating everything, sees my heart and like we talk about it and whatever. I just did another triathlon like this past Saturday, same company. And she's like, hey, the heart chest guy. And I'm like, I'm always going to be known as the guy.
So here's the question. What's
Yeah.
next year's anniversary?
I don't know. We'd have to, can I look it up?
Yeah.
I don't know what comes after wax. I'm glad you didn't
Because
give her
now
a
you
jar
can
of
add that.
earwax.
Now you can add that to the list.
It could have been much worse.
We could
It really
save
could.
you.
It could have been much worse,
Traditional-
though. You realize that, right?
What's that?
It could have been much worse. He
I
could have
think
given her like a
it's
jar
nice.
of earwax
I
or
think,
something.
You know, you
Oh,
should start doing stuff like that for Julie.
Oh, yeah. Okay.
So 16th is wax, 17th is furniture.
Oh, okay. That's an easy one.
Yeah.
Well,
18th is porcelain, 19th is bronze, 20th is china. So these were pretty boring. Like,
yeah, the wax one is
The wax,
nothing
you
deep.
had to do it. You
Yeah.
know, it's just.
And Mom didn't know this story, did she?
I don't know any story.
why would I tell her? Like, oh, that's what your son did. Aren't you so proud? Like,
Well, that was awesome.
So
Thank you.
I've learned a lot today. I mean, I've learned so much today, really. I've learned that shoulder is very complicated.
Mhm.
We've learned about frozen shoulder, a little bit about rotator cuff disease in general. We've learned about maybe when to do some imaging, when not, role of physical therapy, all of that, stretching versus non-stretching. And I've learned that
He has a second career.
yeah, I've learned you have a second career potentially, and we've learned that doctors are human, right? That's something people have to remember, right? We all have our own personalities, and
and I think
it's important to know.
to put all of those things together, I would say that it's normal for people to be worried to go see the doctor,
Of course,
right? And why does somebody live with shoulder pain for a year, right? Because they're afraid of hearing bad news, or they're afraid of being talked into something that they don't want to do,
right?
right? So if, as a medical community, we can do a better job of establishing the trust with people
The
to
listening,
know,
right,
yeah,
the listening.
like just listen. If you want to come in and just tell me, my wife made me come, I don't want to be here. Great. What do you want to talk about? Don't we have to talk about my shoulder? No, we don't have to talk about that. Like, we can. I'm not going to talk you into anything. I'm not going to force you to do
Right,
anything.
right.
Like, if you just want some, sort of open-ended information about what could be causing your shoulder pain, and then you choose to ignore me completely, that's totally fine. Like,
Right.
either way, I'm here. Like, I'm not going anywhere. So come, have the conversation. If you feel like it makes sense to do something, let's do something. If it makes sense to continue to ignore it, I might be the one to tell you, like, it looks like you're doing okay. Why don't you just
Right.
keep doing what you're doing?
So
the-
one of the really nice things when I was researching you a little bit was you have that link on when you put in your name, it comes up with Primacare and who you are. But you have a link to a great article that you wrote, A Tale of Two Shoulders.
Yeah.
And I think for anyone that's kind of thinking about this and running it around in their head, like that's a great piece to read.
Yep.
Just to kind of talk about how you talk someone through and what the considerations are.
I really love the fact that you put so much priority in communication and listening. to
Yeah.
patients. It's really probably our most important tool as physicians.
Huge.
Quite honestly, is that just
Right.
that and
Listen, if we were technicians,
right.
then people could just drop off their shoulder, would take care of it for them, and then
Right,
pick it up in 2 weeks, right?
Right.
And I tell people, I'm like, that would be much easier for you. It would be much, 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 much easier for me.
Right.
Just drop it off. We'll take care of it. Like, oh, sorry, there's a delay. We need a part. Like, it'll be another week. No big deal, right? But these things are attached to people.
Right.
And if these
Right.
people are struggling with whatever it is, like I had a lady, so I don't want to specialize in this, but I think you're left and I'm left sometimes with people's emotional issues
Mm-hmm.
because they've ignored them.
Right.
And if nobody's asked this question, and like we're in the unfortunate position where like, like my wife makes fun of me because she's a therapist, like she's a master's in social work with a clinical practice,
Right.
and she does teletherapy and stuff. She's like, you're not qualified to do that. I'm like, I'm not, but like if I'm all these people have that
Right.
they got into a bad car accident and they've had exceptional treatment. They've gone to this doctor, that doctor, this therapist, this treatment, that treatment, and they're not getting better. And I just asked a simple question like, is the accident traumatic? Like, what do you mean? Like, have you processed it? Processed what? Okay, you got into a car accident. You physically injured yourself. There was an emotional injury.
Mm-hmm.
How are you dealing with that?
That's a
Freeze.
great question.
Freeze, like complete freeze,
Yeah.
right? You like, yes, I do see sometimes somebody comes in and like, yeah, they had the cortisone injection, but it was in the wrong place or it wasn't done with image guidance. Like, oh, okay, like that's easy stuff. Like, okay, like, let's give you the injection with the image guidance. Let's get it exactly where it needs to go. Oh, you had an operation and, it didn't give you all the results that you want. Let's do a second operation and, we'll be able to get it right. Fine. I think that stuff's easy, but to sit there and be like, how are you dealing with this? I'm not qualified to do that.
No, but at least you ask the question. Like, we don't breathe.
And it's
sometimes.
really not that hard, right?
No,
It's
right,
really
though.
not that hard just to be like, how are you, like, is this like still upsetting to you? And they know that's not why they're there.
Right.
And they know that's why I'm not why I'm there.
Right.
But they realize just by being asked the question, from their response to the question, that's at least part of the equation.
Right.
Mm-hmm.
Right?
Right.
And trying to understand people, what they really need, I think is a more important part of the job.
Sure.
Right?
Well, I mean, if you don't understand what their fears are, right, then the patient very often can make the wrong decision.
Yes,
And
absolutely.
they can make a decision to have a procedure that may not be appropriate or
to not have it
it.
when they could really
Yeah.
benefit from
Because,
it.
for example, in my situation, the reason I said, hell no, I'm not going to have surgery was because I had seen, some patients who had neck surgeries and I didn't want to have neck surgery.
Right.
I probably should have gone to see someone, even though I'm a physician. I probably should have at least gone for a consultation. It worked out okay in the long run for me. That's good. But some of my decision making was based on fear. So it's important to have those conversations so
Yeah.
people understand the decisions that they're making.
Yeah. And we're like you said, we're humans. We're
Right.
not immune to it.
Right.
Right? Like, should I mean, I tell my patients, I might as well tell you guys, I'm the worst patient, right?
Mhm.
Like,
Yeah. It's true.
I drive my primary is Dr. Soriel,
Yeah.
and I feel bad for the poor guy. He tried to get me on a statin, for like the last 5 years. I finally started in April. Why did I start in April? Because first of all, I'm stubborn. Second of all, I felt like I wasn't taking care of myself well enough, right? And I had a lot of weight to lose. And I went to the Medi weight loss and I worked with them and I lost a lot of weight. And just like he said, it didn't fix my cholesterol,
Right.
right? But I wanted to try,
Right.
right? I want to try. I want to do it
Right.
myself.
That's
and,
okay.
Okay. So I tried and I didn't do it. And, now I'm taking
It's
the
a
statin,
process.
right?
It's always a process.
So if we know, right, and we understand that like the intellectual gap isn't there and people still aren't doing the right thing,
Right.
then we have to understand there's something more to it.
Right.
It's not just the technical know-how. Oh, I know how to do a perfect rotator cuff repair. Okay, well, if the patient doesn't buy in, doesn't wear their sling, doesn't do their rehab, they end up worse off.
Right.
So if I don't have that conversation on the front end, are you ready? Are you prepared to wear a sling for 6 weeks and do nothing?
Mm-hmm.
And of course, there's the patients who swear up and down, yes, yes,
Sure.
yes, 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 and then they take the sling off to mow the lawn the week after surgery.
Yeah, and that's like really caring about the whole patient. We hear that term a
100%.
lot, but,
But it
we
means something.
don't exactly. It's
It
we
means
don't
something.
always see it in practice.
It
like,
means something,
exactly.
right?
So this has been great. We've talked not only about the shoulder, but the philosophy of taking care of patients, which I didn't expect we'd get into as much, but it was really
great.
fascinating. It's always interesting to talk about that with
Yeah.
other physicians and to hear their point of view. Is there one thing you'd like to leave our audience with today?
I would say that it's okay to be critical, but not necessary to be scared.
Mm-hmm.
So if you go see someone and like, let's say you come and see me, right? So like, it's not like, oh, there's good doctors and bad doctors. You come see me. I'm having a bad day.
Mm.
Whatever it is, something happened. I didn't sleep, whatever. Like, I'm worried about my mom. I'm worried about my kids. Whatever. I'm having a bad day for whatever reason. And you don't think that I heard you. You have options, right? If I didn't do a good job and you don't feel like you were taken seriously, or that I recommended something but it didn't make sense to you and it didn't seem like, even if I was, right? Even if, like, I wish you told me, because if you had told me I didn't want to do that, I would have come up with something else. But for whatever reason, I gave off the vibe that I'm telling you what to do. You have options. Go get a second opinion. Go talk to your primary, right? The primaries know, right? They know who's going to talk you into stuff and who's going to, you know,
we do.
right? So go and find someone else. But don't be scared, right? If you're not satisfied with who's in front of you, find someone else and get an answer that satisfies you, because most problems have some reasonable solution. And sometimes there is no solution. But there's a skill and there's a way to approach people so that they know that they're being cared about, even in the absence of a solution. And you should feel that way. You have the right to feel that way, that even though your problem wasn't fixed, that you were attended to and you were taken care of.
Right.
Beautifully said.
That's great.
So,
Great advice.
yeah.
How do patients contact you?
I have a website, primacareortho.com, with lots of modules where you can read some more. I have a Medium platform, so if you just Google my last name, Mesiha, and the word Medium, you can read some more articles. So that Tale of Two Shoulders article was, you know, in the local paper, but I've got, you know, other publications there. My office number is 508-617-9740. My email is mmesiha, so my first initial, my last name, Mesiha, at prima-care.com. And I'm really excited to do this new venture with Doctorpedia. And it's a new thing that actually, since the time that you and I talked about doing this, and today, you remember you said, oh, you know, it would be so fun to have you on the podcast. I'm like, yeah, I've been dying to do stuff like that, but I just haven't quite gotten into it. So Doctorpedia is this really cool new platform that I think has the right idea about how to get this kind of information out to people.
Nice.
And it's like these little, like, 90-second, 2-minute clips of, like, you know, how to think about this problem. So I'm really excited to work with them. So hopefully over the course of the next several months, there will be more content on Doctorpedia.
Great.
Perfect.
Well, I really want to thank Dr. Mesiha and Dr. Mesiha for being on the show. This was really great. It was educational. I'm sure that our viewers learned a lot too. And we went in a lot of different directions, but it was all fascinating. And I want to thank Bay Coast Bank, which is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thanks for tuning in to the 27 Degree with Chris and Nancy from 27 Degrees Consulting, and we'll see you back in a couple weeks. Take care.